I'm a medical oncologist and currently I am the Director of Clinical Trials for the Faculty of Medicine and Health Sciences at Macquarie University. I'm still running the Clinical Trials Unit at Westmead Hospital too, in the Medical Oncology Unit, so I actually run two trials units in a large part of Sydney. My reason to get into clinical trials is because medicine, the human body and the disease processes are so complex that we cannot possibly understand them. And clinical trials is the conduit to understand things more and therefore improve patient care. So I worked as a medical oncology trainee in various hospitals, and back then doing cancer medicine was all about clinical trials. The treatments were hopeless, to be honest. We have very few drugs. And it became obvious that the only way to make things better was to develop new agents. Medical oncology is all about drug therapies. John Metcalf discovered GCSF, and so I think they were the first proper studies that were done in Australia, the introduction of GCSF, granulocyte colony stimulating factor in the clinic, and how you could actually get human protein and re-inject it into people and see that it actually did something good. It stopped neutropenia and allowed you to give chemotherapy safely in some patients. And then I went overseas to Manchester, and in fact that department's unit was all about clinical trials. You actually didn't see patients unless they were in the clinical trials, and that was really mind-opening. And how you could see from, even in the time that I was there, from 1 year over 2 or 3 years, you could see a new drug introduced, and more than that, how it actually really changed the face of medicine and patient care. If you want to be a medical oncologist, if you want to be in cancer medicine, you really have to be in clinical trials. It's the only way to improve the care of our patients and get more treatment options for them. And negative studies as well. I mean, I used to treat lymphomas, and there was a study of this particular regimen called CHOP and another quite aggressive regimen called MACOP-B, and everybody was using MACOP-B because we all believed that that was better and you're going to cure more patients with lymphoma. And so the study was done. I was an investigator. It was a negative study, and that was a real eye-opener. Like, everybody thought, this MACOP-B is better, you're going to cure more. Why do we have to do this study? And of course the study came out, it was no better. That showed me that you can't just make it up as you go along. These things that we intrinsically believe in our gut, that this is going to be good, often is wrong. And the only way you can find out whether something's better or not is to do a randomised clinical trial. If you're offered a clinical trial, seriously consider it. If you're not on a clinical trial and you're not offered a clinical trial, I would suggest you look for one that might suit you, and there are various websites that you can track down. So for the Australian one, it's australianclinicaltrials.gov.au, and then you can search on those about your particular illness, whatever it is, and a number of trials will come up, and usually there's got a contact for the various sites where the trial's being undertaken. Australia's reputation in clinical trials is excellent. We have a good reputation worldwide for getting good data, often quickly, accruing well to trials, and being able to do it in a cost-effective manner. If you're not being involved with trials, get involved with trials. It's good for your patients. It's also good for you. It's good for your CV. But also you become the expert. My legacy, I guess, would be to building up good clinical trial units that can efficiently look after the patients and undertake these clinical trials in a lot of patients, not just 1 or 2. A lot of Australians can benefit from doing clinical trials generally and get access to these drugs and hopefully make their disease better. So I guess that's the thing that most satisfies me.